Welcome to another episode of Well-Adjusted Mama. I'm your host, Dr. Laura Brayton, and today's guest is Jennifer Lisimachio, who is an international board-certified lactation consultant in the Hoboken, New Jersey area, and she will be speaking today on resolution of nursing challenges. Jennifer Lisimachio, IBCLC, is a partner of Mahala Lactation and Perinatal Services, and she heads up the Northeast New Jersey and Greater New York City area. She operates the Mahala Breastfeeding Center in Hoboken, New Jersey. She is an international board-certified lactation consultant and an accredited Leche League Leader since 2001. Jennifer is a member of the Professional Liaison Department of Leche League, New Jersey, where her 14 years of professional experience and knowledge in current lactation research is used to support fellow Leche League leaders. She is a member of the New Jersey Breastfeeding Coalition, New York Lactation Consultant Association, ILCA, USLCA, and IATP. She enjoys speaking at area conferences on lactation and infant development, in addition to organizing community World Breastfeeding Week events and fundraisers. Jennifer has mentored and trained leader applicants through the application process. Jennifer is a former fashion model and studied French and French literature at Université Paris Sorbonne in Paris, France, where she lived for 6 years. Her passion for breastfeeding began in 1998 with the birth of her first son in Paris and followed her to New Jersey, where her second son was born with many difficulties latching and coordinating suckling. Her research to understand and support her son's particular breastfeeding challenges led to her interest in neonatal sensory processing and neurobehavioral approaches to breastfeeding. Her expertise in skin-to-skin contact and kangaroo care is frequently called upon within the lactation community. Jennifer's mission is to encourage, educate, and empower mothers and families through breastfeeding. She lives in Jersey City, New Jersey, with her husband, 2 breastfed boys, and their golden retriever, Amber. For more information, please visit her website at mahalamom.com. Welcome, Jennifer, to the call. I'm so excited to have you on the show today.
I'm very excited as well. Thank you so much for having me.
So with Well-Adjusted Mama, we've had a couple lactation consultants come on in the past and speak on tongue and lip tie and co-sleeping with nursing mothers. But I'm really excited for you to share your perspective on breastfeeding and nursing, because I know you have your own story to share as well. And so let's start off with talking about kind of why you are so passionate about nursing, breastfeeding, and everything related to that.
Sure. Well, I have 2 sons. I have Max, who is 17 years old, and Noah, who is 12 and a half. And it was really my first son, Max, who led me on my journey to, through breastfeeding and ending up getting into becoming a lactation consultant. He was born in France, and at the time when I was pregnant, I had a friend of mine who was like, hey, you should come to this meeting. And it was a little meeting called the Leche League, which is internationally recognized organization. And I was pregnant, and I really, I just kind of thought about, my pregnancy, and I thought I was going to try to breastfeed. I thought, well, yeah, I think it's a good thing for my son, for myself. It's a great bonding. So that was kind of my first foray into breastfeeding, was attending a Leche League meeting when I was pregnant, and then learning all about kind of the philosophy and what they're about. And they prepared me pretty well for when I gave birth and started that first breastfeeding relationship with my son Max, who was a natural-born nurser. He just came out of the womb and got on the breast, and he actually made it very easy for me. He knew what he was doing. I really was just figuring it out as I was going. Excuse me. He was what one would call a very high-need baby. That's not a term that I love, because I feel that all babies require a lot of attention and they have a lot of needs, but he really just wanted to be with me all the time, being held or nursed or carried. And again, I turned to the Leche League to get the support and really started to understand how infants developed. What they needed was a basic need. Being held was not a terrible thing. I was not going to spoil my baby by giving him too much love. And that's kind of the philosophy. It kind of led me into establishing this beautiful relationship with my son that went beyond just, the breast milk. Some of the philosophies of the Leche League were very profound and are still profound to me. It's, mothering through breastfeeding is the most natural and effective way of understanding and satisfying your baby's needs. And that's very true. It really allows you to establish a great relationship with your child. We need to be together early and often to establish a satisfying relationship and adequate milk production. Babies need to nurse a lot and often early on, and that really helps with building up milk production. In the early years, babies have this intense need to be with mothers, which is as basic as their need for food. And as we all know, breast milk is the superior infant food. And it's really the only food necessary until the baby shows signs of needing solid foods, which is after 6 months of life. And, through the Leche League and, again, one of their philosophies of that the breastfeeding relationship will continue until the baby outgrows that need, which is not months, it's years. If we look at, the anthropological studies of breastfeeding, being alert in childbirth also really helped me getting breastfeeding off to a great start. I had no interventions and had a normal non-medicated vaginal delivery, which really allowed him to be alert and do what he needed to do instinctually with all of his intact infant reflexes. I couldn't have done it without, his father, who was a wonderful supporter of me and our relationship. And, those are just some of the philosophies of the Leche League that I really, felt at home with, and that led me to become a Leche League leader when he was about 2 years of age. And leaders are, accredited volunteers who have first and foremost breastfed their own babies, and have a good relationship with breastfeeding through their own child. And they've been specially trained to help with the mothers and breastfeeding. There's meetings. I know that in Hoboken, Jersey City, there are about 3 meetings per month for mommies to get together and meet and discuss things with the leaders. And, it's just a wonderful time to meet other mommies that are going through the same situations that they are, as well as getting advice and help from the moms that they're meeting. When my second son, Noah, was born, that was in 2003. We had moved to America at that point, and I knew that I wanted to birth him at home. So I was able to have wonderful midwives that helped me bring him into the world. He was a water baby, hence the name Noah was very apropos for him. And having had a child who previously who was extremely vocal about what he needed from me, when Noah was born, I recognized pretty clearly and rapidly that he had some challenges. He definitely had problems with coming to the breast and with suckling, and he had some sensory issues that were very difficult for him. And it was actually through those experiences that pushed me into my career as a lactation consultant. I am so grateful that he was my second son and that Max was there to actually teach me how to be a mom and how to, support my children wherever they need to be met. And I think that he really helped me discover the power that I had to help and heal my son, Noah. And that was pretty stressful. We had a lot of nursing challenges, and we just worked through them with a lot of help and a lot of love and a lot of support. And he is an amazing child today. And as I said, that pushed me to the next step of becoming, trying to get my certification to become an IBCLC. So that's a little bit about my beginnings.
Yeah, I think it's such a beautiful story. You had 2 really beautiful births, and for some moms, the first baby can have a lot of challenges with nursing, and it's so overwhelming because you're a new mom, new to having a newborn and having challenges with nursing. So it's cool that Max, knew how to nurse and was able to take on to it easily. And that was a good contrast for you with your second child to see what was normal, what wasn't, and then how you could support him in being successful with nursing.
Absolutely, yes. I'm very grateful for both of those experiences.
Right, exactly. And that also, I'm sure, is so valuable for when you're working with moms who have a plethora of different scenarios, and you have 2 different scenarios, personal scenarios that you can, draw upon to share with those moms.
Absolutely.
I was going to ask, how long did you nurse both of your sons?
Well, Max, he self-weaned when he was a little over 4.5. It was soon after the birth of Noah. So I did tandem nurse them throughout my pregnancy, or I nursed him throughout my pregnancy, rather. And he was nursing until Noah was about 3 months old, so pretty long time.
Yeah. And so there was 3 months that they overlap.
Yes,
that's so cool.
Absolutely. Which is very helpful for those when I was very engorged,
Yeah. That's so true. And, I think a lot of listeners might be kind of surprised to hear that. So, do you want to even talk about maybe how other parts of the world do typically, nurse longer than what we see in the United States?
Absolutely. Well, one thing that a lot of people don't realize when I ask them in group settings, I always ask them the question of, what do you guys think is the average age of weaning in the world? And they just start throwing out random numbers, 6 months, 1 year, 18 months, and I keep, telling them to go higher. And I can see that they start getting a little shocked once we hit, 18 months. And, the truth is that the average age of weaning is over 4 years of age. And that's the average. So, in America, that's not typically what we're seeing happening. The American Academy of Pediatrics, their statement on breastfeeding is that ideally all babies should be exclusively breastfed for the first 6 months of life, and that means just breast milk, no supplementation of formula, no water, no solid food introduction before the six months of age, and that baby should continue to nurse for at least the first year or as long after as is mutually desirable for both mother and baby. The World Health Organization goes a step further than that. They say the exact same thing, that all babies should be exclusively breastfed for the first 6 months of life, but that it should continue for at least the first 2 years and as long after as is mutually desirable for both mother and baby. So we have a long way to go in America, and, myself and my colleagues that are, working with mommies and that are IBCLCs, we are trying to, encourage and promote, breastfeeding, and as long as is comfortable for the dyad and for the family. Everybody has to make their own decision that works for them, and their own family. I can tell you that when I was pregnant, I was never thinking, I'm going to nurse this child for years. I was just saying to myself, you know what, I just want to get through a week, and then a month turned into 2, and so on and so forth. So. Right.
I think with any goal, you don't want to be overwhelmed with creating a artificial deadline or timeline. You just
exactly, yeah, or expectations for sure.
Right. That's so true. How long did Noah get nursed for?
He weaned a little bit earlier. He weaned when he was about 3.5.
Yeah.
So he nursed for about a year less than Max. But the reality is, when he was first born, I was just, again, I went right back to when I was pregnant the first time. If I can just get him through this week or this month. And, you know, we had a lot of challenges. So every day that we were continuing to nurse was a success. And that's kind of what I went on when I had Noah.
Yeah.
So the fact that he made it to 3.5 years, I was actually pretty surprised. So.
Right. Yeah. That's amazing. And, you know, I think that, you know, with women that are having challenges, you know, it's so easy to be so overwhelmed if you're not getting the support you need and just, you know, discontinue nursing in general. So I would like to kind of switch gears and talk about maybe some of the challenges that can occur, that are real, that can occur with nursing, especially, you know, in the very beginning. And, you know, if you could share what some of them are and then how moms can get the support they need to overcome those challenges.
Sure. Well, I think that even when breastfeeding is going well, it's extremely challenging in so many different ways. It is, you know, it's a natural biological process, but it is, for most women, it's so not natural, and it's a lot of hard work. And I think it starts with having your support group and having the people around you that are going to be there to help you through the process and support you through the process. Women today are, you know, giving birth in very hard and traumatic circumstances, and, you know, childbirth and those impacts really impact lactation and the processes. So, you know, it starts in the hospital. It starts with, you know, all of the medications that our mommies are given with, you know, we have high induction rates in America and high cesarean section rates in America. So those interventions during childbirth can themselves lead to a lot of challenges with breastfeeding for both mommy and baby. Typically, mommies are going to have some, you know, the very typical nipple pain, sore nipples, problems with just getting the hang of it, positioning and latch. And, you know, when you first give birth, what happens in the hospital is women are being told 5 different things from 5 different people, and they're really getting mixed signals on what to do as it relates to breastfeeding. A lot of mommies really are looking to see an IBCLC when they do have a history of either nipple or breast surgery, whether that be augmentation, reduction, biopsies in the breast that can impact milk production. Women that have had a history of any kind of hormonal or anatomical challenges, whether that be thyroid and PCOS, polycystic ovarian syndrome, any problems with infertility, that's hormonal. Lactation is very hormonally based. Flat or inverted nipples can be very challenging for moms, and as well as insufficient glandular tissue, which is, you know, basically not having enough stuff in the breast that makes the milk. And sometimes we can see that through pregnancy, you know, you're already starting to prepare. The body is preparing for breastfeeding and lactation through increased breast size, tenderness of the nipples, darkening of the areola. And when mommies don't see some of those breast changes, that can be an indicator of some issues with milk production. You know, asymmetry of the breasts, that can be something going on that can inhibit milk production as well. And a lot of times mommies, you know, they've had a child or two that they had a lot of challenges with breastfeeding, and they're very scared and they want to do it again. So they're looking to have a consultation just to make sure that they don't have another repeat of a bad breastfeeding experience. So they look to get some help and seek help from an IBCLC. I work with a lot of mommies that are adopting babies, and it's pretty amazing. They're adopting babies and they want to start lactating. And you don't necessarily have to be pregnant to try to nurse your baby and make milk. And that can be done, even with a supplementing nursing system at the breast. Mommies that give birth prematurely, those, a lot of times they are not able to see the babies or hold the babies for a couple weeks. And, helping them establish milk production through, hospital grade pump. And, once the baby is able to start nursing with that transition as they mature and develop, or mommies that have multiples, twins, they need a lot of help too. You have the babies that are, special needs babies that have, some genetic conditions or some health conditions. They need some support. Other reasons for, having a consultation or having problems with nursing would be, separation from baby after birth. As I said, the latching and positioning difficulty, that's pretty common in most cases. And anatomically, babies' mouths can cause difficulty with breastfeeding if there's a cleft lip or cleft palate or tongue or lip tie. Any of those things can make it a challenging situation. Mommies also, they have a lot of problems when their milk comes in and they're very engorged on, day 2, 3. And sometimes babies are like, wow, this is too hard for me to latch onto these breasts. And that's very difficult and it can be very, very painful. Milk that doesn't come in by day 5, that's a sign that there's something going on with the mommy's milk production, or maybe the baby is having a hard time removing the milk to start that onset of milk production. A very common one is breast pain and nipple pain or trauma. Mommies are getting chewed up and, it can be just something as simple as correcting the latch and positioning, or it could be something, again, like a tongue or lip tie or something a little bit more, anatomical. Sometimes babies have a hard time with gaining weight. They may lose a lot of weight after birth and then, gain it very slowly. And that's very worrisome. Babies can fall asleep very quickly or sleep through feedings. And so we need to figure out what is going on with that baby. Baby could be jaundice and very sleepy baby. Babies could be very colicky and crying a lot and never, seem satisfied. I hear from a lot of mommies that the baby just wants to be on the breast all the time. And that combined with, slow weight gain, that can be a red flag, for, the baby having a challenge at the breast. A lot of mommies just need somebody that, if they don't have a really good support system at home, they are looking for somebody that can reassure them that everything is just going just fine. And sometimes they look to a professional to get that reassurance if they're not getting that at home. And, as I said, you can, in some cases, nurse while pregnant, if you're not at any health risk. And we also help with bottle feeding and supplementing and knowing, when is that necessary, and when it is necessary, we are very grateful that there is formula to be able to help these babies thrive. The most important thing is that babies are fed and that they thrive. We don't want our babies, starving, while they're trying to make baby, breastfeeding work. So, if sometimes babies need some calories and some formula to get them strong and get them nursing better. And the next thing is to really protect and establish, mommy's milk production. And then we can be patient with, mommy and baby as we assess exactly what's going on and how to help, them reach their breastfeeding goals. So those are some of the reasons why mommies and babies can have some challenges after birth.
Yeah, I mean, there's a lot of things that you just listed there. And, I was even hearing, like a mom is, let's say, having difficulty and like to your point, the baby just needs to get some nourishment. There are even milk donors out there if she's not able to get the baby, fully draining her breast at the beginning, she can maybe supplement with that, from women that are overproducing and having excess donate. So that's a really cool option as well for some women.
And we definitely need to have more milk banks in America. I know in France in 1998, when I gave birth to my first son, there were milk banks in every hospital. That's what they would give their babies in the NICU, and we don't have that. We need to have, more milk banks in this country so that moms do have that option if they, don't have a family member or sister or somebody that is nursing that can donate their milk, that they have that option as well. So we also need to work on that in America too.
Oh, I agree. I mean, that could be a whole nother conversation, but there's any milk banks in the United States, and then there's a lot of legality around the safety, wanting to pasteurize the milk and kind of, things that aren't necessarily natural. And then at the same time, because the supply is so low, that milk may be available for some, NICU, like, these preemies and these babies. But what about a non-preemie baby whose mother just is unable to nurse because maybe she had double mastectomy or whatever, and still wants to provide her child with breast milk? So there's so many having more options with being able to donate and having it in an organized fashion, I think would be really awesome.
Absolutely. I agree. And there's some danger with, milk sharing. I definitely, there are some risks with, on the internet, you can find some places where mommies are donating their milk. There are risks associated with that. There can be infection in the milk. There can be some bacteria in the milk. There could be some issues with storage, contamination with milk storage and shipping. So we need to provide our mommies a safe alternative so that they don't feel like they need to go on the internet to start looking for somebody's breast milk. So
Right. Yeah, I agree. It needs to be standardized for sure, and that way the milk is safe for the baby. So that's so true. So, you talked a little bit about some sensory issues and challenges you had with your second son. Can you maybe explain a little bit more about what's normal regarding neonatal sensory processing and how that can impact nursing?
Sure. Well, when a baby is born, they're in this familiar womb environment. Hardly any light comes in. The sound from the outside world is, kind of muffled. And they come out into this world that is so scary. All these sensations are just coming at them. And the baby is going to see this through his eyes, ears, the mouth, the skin, the nose, and the body. And, in the following weeks or so and months, a baby's main education will be to, understand exactly what those senses that are coming at them tell him about the world. Not all babies are able to process this sensory information as well as the others. If a baby has difficulties in, sensory integration, which includes sensory processing and sensory responsiveness, this can be, translate into certain behaviors that may be confusing for the parents. Babies are, they're amazing little creatures. If a baby's, being difficult, it's because he's having difficulties. I hear that a lot, the baby cries, the baby's lazy, all of these kind of labels, but, they're trying to communicate that they're having difficulties. Respecting those signals and remaining patient is kind of first training for parents. For adults, it is normal to have, slight sensory issues. And it really becomes an issue when, it makes it difficult for a person to feel comfortable in his or her own skin. All of us react to our surroundings according to how, our surroundings are coming at us through those senses. Sometimes we can't tolerate certain odors or are sensitive to noise or light or even to, tight or scratchy clothing. And that's how we kind of react to that. People often don't even recognize their own sensory issues without even thinking about it. We kind of develop these preferences and avoidances that make life choices. We make life choices that help us feel comfortable in our world. A baby has a hard time making these kinds of choices. He cannot tell us what is causing him to feel badly or how we can help. We have to try to recognize if the baby's having issues and trying to help this baby feel safe and comfortable. For example, if a baby is very lethargic or seems to be sleeping all of the time or fussy and seems to never want to settle, obviously it's important to talk to your healthcare provider to make sure that there are no other health problems before exploring whether your baby is reacting to kind of a sensory overload. For the fussy, unsettled baby, he might cry hard and long and be very difficult to soothe. Babies cry. They all cry and it breaks our heart. But if your baby tends to cry for hours and hours at a time, in spite of what you are continually trying to do to calm him, that may be, him showing difficulty processing the information, that is coming at him. A lot of times you'll hear that, oh, this baby is so easily, overstimulated. And, you want to make sure that there's nothing, again, medical like reflux or any kind of injury. A sleepy baby, a baby that's very placid, may have difficulties, having those senses coming at them. People call this baby a good baby sometimes. Oh, the baby's sleeping all the time. What a good baby. I hate that. I hate good baby. All babies are good.
Right. That's true.
Right? But you hear that a lot, Right. All babies are good, even if they're crying, right?
Right.
But this baby may need to be awakened, very frequently to eat. And discovering what a baby needs can be very difficult, for a parent and very frustrating. Your baby may not like the way his blanket feels. And he also might have, things like, wants to always be in motion. So it's like figuring out exactly what is working for your baby. We take the information from the environment through our senses, constantly. And, these messages travel to the brain through these nerve channels. Our brain processes the information and then we can react. Developing and growing is learning which of those nerve signals are important to us and which ones we can kind of, leave behind. If the baby's constantly hearing the sound of the clock ticking in the background, pretty soon they will learn to ignore or just, disregard this sound. Babies that are like hyper-responsive or responsive, they have lots of difficulties as well. Hyper-responsiveness or undersensitivity is basically when not enough of the information gets through to the brain. So the baby feels less of the sensation, less is getting focused on into the brain. And hyper-responsiveness is the opposite. It's oversensitivity. It's when every sense, every feeling, every movement registers as being very strong. Babies already experiencing stress have a greater reaction to sensory stimuli. And they have changing levels of tolerance that can be unpredictable, just like we have. Something can happen and then, you get stuck in traffic one day and you get very angry about it. And the next day it'll be the same situation and you're just like, yeah, okay. So I'll be a little bit late. So sometimes we react to different things and depending on what our mood is. So as babies mature, so does this sensory processing. The earlier the age that treatment can begin, the faster and more beneficial it will be. Touch, okay, so that's another sense. And touch-sensitive babies are very distressed when sensitive parts of their body feel contact. They might look uncomfortable or get very fussy, depending on what clothing or fabrics that they have on their body. And they're sometimes even sensitive to particular types of touch, whether that be a light touch or a firm touch. Some babies actually find a firm touch is very calming and soothing. Other babies would not be able to handle that, and they prefer more of a lighter touch. Babies who like deep touch may relax when they are held very close or swaddled. Sensitive babies may, sometimes they're called uncuddly, or they don't want to be held. Sight, a light sensitive baby can sleep all day to avoid, overstimulation of light. They may need to be awakened to eat during the daytime, and they may be so overwhelmed by the light that they prefer eating at night. So they'll reverse cycle and want to feed a little bit more during the evening time. Now we have our sound sensitive babies, and they too may sleep through any noise or wake at the sound of, this softest sound, depending on whether they're hyper or hypo responsive. And again, these babies tend to prefer to eat a little bit more during the evening times. Discovering what a baby needs is extremely complex and frustrating, Smell, also the smell sensitive babies can be distracted by odors, both pleasant and not so pleasant. Sometimes other people would never even notice them, but some people are very sensitive to smell, as well as taste. Some babies, they don't particularly like some things that the mothers have eaten, and they taste it in their breast milk. And then we go into the movement and the balance, where, they may need to be rocked a certain way, or they may, cry a lot when they're handled too much, and they prefer to be kind of on their own. And, sometimes babies, they don't even have they don't have a great sense of where their body is in relation to, like, their feet to their hands. It takes some time to recognize he has power over his hands and feet, and that they even exist. So there are many different things, and sensory integration can impact, breastfeeding. For babies that are having some challenges with touch, things that you can try are to identify which areas are sensitive to touch on the baby's body. Figuring out exactly what kind of touch bothers the baby. Is it firm touch or light touch? If a baby likes a firm touch, you can hold in a firm embrace, and consider something like swaddling can be very helpful. A baby that does not like light touch will not like to be stroked while he's nursing. So we want to avoid that. We want to try to avoid setting off those triggers. If the baby has a sensitive head, we don't want to put pressure on the back of the baby's head while trying to feed. For light sensitivity, we want to be in a dimmer room to nurse, and you can try shielding the baby's eyes to allow them to relax. Babies that are, sensitive to sound, they want to be in a quiet room to feed. And sometimes mothers like to put like white noise on in the background to kind of help drown out some of the other senses of sounds that are coming at them. Sing a little lullaby that they get used to, that they like. And, for mommies that are using nipple creams or lanolin on their nipples to help with nipple soreness, the babies that are having some sensitivities to smell and taste, that might be too much for them. So we want to make sure that there are no creams or lotions or perfumes that can interact and make babies fussy to the point of not wanting to feed. And again, as I said before, there might be something that a mommy eats that really affects, the taste of the milk and that they don't like. So you might want to take a look at your diet. Movement for babies that, want to be kept still. Different positionings can be very helpful. Some babies really like to be in one position, lying on the baby on his side with pillows supporting him and mom can be very helpful. Nursing a baby in a sling can be very, very helpful as well. Mom may need to sit or stand without moving very much, so as not to overstimulate this movement-sensitive baby. And, the babies that like movement, like my second son, he would only nurse with me running around the block outside in a sling. And I needed to nurse him in the sling. And he needed to feel all of that movement before his brain connected to, okay, now I can nurse now. So the, constant stimulation and movement was very important to my son, bouncing on an exercise ball. And, sometimes vibration can be very helpful. There are lots of different things that we can do to help these babies. And, the beautiful thing is the brain is developing so beautifully. And as Dr. Nils Bergman says, when it fires, it wires, meaning when we make babies have those connections and the synapses in the brain start firing, then it sticks, and we can actually help heal that brain and help them get through this. It's very challenging for new parents, and a lot of times you'll hear, "Oh, that's normal," or "He's just fussy," or "He's just needy," and "Oh, you're going to spoil him if you hold him too much." We send a lot of mixed signals to our mommies, and it's important that we can help our dyads find, answers to these puzzling behaviors. And, it's really just important to remember, as I said, there are no difficult babies. There are only babies who are having these difficulties.
Right.
Wow. So that's a little bit.
Yeah, that was a lot of really valuable information.
That was a lot.
I don't think this information's really mainstream, and
Right.
I think when babies are having challenges and difficulties, like you said, instead of labeling this baby as being bad or, a difficult, like that baby's not choosing to be difficult or have bad behavior. This is totally instinctual, and they're really, making that their needs known. And I think a lot of it can be hard for a new parent to interpret if they don't know what to do, but these can be all great signals of things they can try with their baby, and through trial and error, find out what works best for their baby. Are there any resources that you could recommend for parents that are noticing, okay, my child's having some sensory issues and I don't know what to do about it?
Absolutely. If you have concerns, I think it's important to ask, for a referral to a specialist. Occupational therapist with infant feeding and sensory processing expertise is a great resource if you are suspecting that there's sensory integration or sensory processing disorder going on. Also, sometimes feeding therapists, speech language pathologists, physical therapists, chiropractors. You want to just make sure that the specialists that you find do have, extended experience with infant feeding and sensory needs. Other treatments also are craniosacral therapy and getting some neurodevelopmental treatment. I think each type of therapist and each kind of therapy has a different approach. So, if you don't find somebody that, that you're clicking with, keep looking until you find the right one and the one that you feel comfortable with. And sometimes it's multiple practitioners working together that can really help get the infant to where they need quicker. You can go to www.spdnetwork.org. It does have a lot of really great information for parents and professionals about sensory integration. That's a really great place to start if you suspect that your baby may be struggling with some of these sensory disorders or dysfunctions.
Wow, that's great. That's such really valuable information, I think, for parents to know that this is out there, and it's something that, I think that maybe the average pediatrician doesn't have a lot of experience with. And so, sometimes they might be just quick to say, well, nursing's not working for you. Why don't you just do formula? And, for moms that are really wanting to provide breast milk for their baby, there are some solutions that might be available.
Absolutely. I hear that a lot. And, well, the baby is just a lazy feeder, a lazy nurser, just not made to do this. Oh, it's okay. We can just give the baby a bottle. On one hand, yes, if the baby is having a hard time at the breast, if we can get milk into the baby via bottle, that's a great thing. So the baby, is getting, nourishment. But what I would like to say is if the baby were born, and having difficulty, breathing, and there were some issues, respiratory issues, what would we say to that parent and that baby? We take care of that baby. We figure out what is going on. What is the problem? Why is this baby having these respiratory issues? Well, breathing is just as important and just as instinctual as feeding. And when a baby is having problems and challenges with nursing at the breast, we need to figure out exactly why. And I think a lot of mommies aren't getting that kind of treatment because we don't look at it as something that is a reflex and an instinct and is vital to an infant thriving. For me, a baby having a problem feeding, it's just as important as a baby having a problem breathing. So we just put a bottle in and forget about it. And sometimes those things that were present at birth, they can show up later on in life or later on as the baby gets older.
Right. Well said. I mean, yeah, to your point, if a baby's having difficulty breathing, we're not going to call that, oh, this baby's a lazy breather,
Exactly. Exactly.
So babies aren't lazy, and feeding is instinctual.
Mm-hmm.
It's not something we have to be, think about. It's just a natural instinct.
Exactly.
The challenge is, let's find out where they are.
Mm-hmm.
That's why lactation consultants are so valuable, to support that mom through those challenges and give, some feedback and some resources and just to educate her, because that's not necessarily happening, like I said, at the pediatrician's office. And that's why there is a specialty of lactation consultants to give that support. So I wanted to
absolutely, and I think it's so important. Yeah. Oh, go ahead. Sorry.
No, you finish your thought.
I was just going to say, I think it's so important that, we as professionals in the healthcare community, we need to work together. All of us have our unique and individual expertise, and it's really important that we continue to work as a team for our mommies and babies.
That's right.
I'm done. Go ahead.
Yeah, I completely agree. We all have our own expertise and areas that we can support, and it's not a one-stop shop type of thing, especially when there are challenges. So, I wanted to switch gears to talking a little bit about tongue and lip tie and what your thoughts are on that. And, do you feel like there is an increased occurrence of it, recently? Have you noticed it's becoming more epidemic, and then when you do diagnose it, what do you recommend for treatment?
Well, I do not diagnose because I am not a doctor,
okay.
But I definitely I got to make that very clear. It is pretty common in my practice, I think, because when a mom and a baby are really, really struggling, they have turned to so many different sources, and by the time they come to me, there's something really serious typically that's going on. If it were, just simple latch and positioning, there are a lot of, even through the Leche League, for example, where they can get some tips. I don't know if there's more occurrence of tongue-tied. The incidence is between 1.7 and 10.7, or about 1 to 4 infants per 100, and can be as high as 25% in infants that are identified as having breastfeeding difficulties. So that wide range is kind of attributed to the different kind of diagnostic criteria used in the study. So, anywhere from 1.7 to 10.7, that's pretty high. I think we're just seeing more of it now that more women are breastfeeding. The campaign of breast is best and breast milk has all these wonderful benefits that, women we don't need to tell mommies anymore, so much about the benefits of breast milk and breastfeeding. They're hearing the message and then they're trying, and then, they're having some difficulties, and sometimes that tongue or the lip restriction, can definitely be associated with that. We do see a lot of breastfeeding difficulties with tongue or lip ties. So did you want me to touch a little bit about what that is, or
yeah,
or not?
That would be great.
Let me know.
Sure. Mm-hmm.
Okay. So the tongue tie is a, congenital oral anomaly. And it is described kind of as the condition in which that normal range of motion of the tongue is restricted due to this attachment of this frenulum or frenum. The International Affiliation of Tongue-Tie Professionals define the tongue tie as the as the embryological remnant of tissue in the midline between the undersurface of the tongue and the floor of the mouth that restricts normal tongue movement. Basically, there's this little piece of skin under the tongue that can make it difficult for that tongue to move around as it should in the mouth. That can be too short, it can be thick, it can be very taut, and it can be attached at the base of the tongue. So, that development actually starts happening when the baby is about 4 weeks in utero. It's very often familial, and, we see it in conditions with otherwise normal and healthy infants. Sometimes we also see it in a combination of a high arch palate, some chin recession, and it can make breastfeeding difficult. It could potentially lead to speech problems, dental and orthodontic problems, failure to thrive, aerophagia, which is excessive intake of air into the stomach. It's typically defined as that restricted tongue mobility. It can be very obvious when looking at the tongue, which is what we would call an anterior tongue restriction, or a little bit more difficult, which is further back in the tongue, and it's a posterior. And both types of tongue ties have been well shown to restrict tongue mobility through ultrasound studies. Geddes in 2008 did a really wonderful study with ultrasound showing kind of the mechanics of babies nursing that are tongue-tied and not tongue-tied. They show, the ultrasound studies show that there's the minimal involvement of the nipple. So the nipple's not really involved so much when the baby's not tongue-tied. And when the baby is tongue-tied, a mechanism for the damage that occurs to the nipple in the tongue-tied child. nursing depends on the baby generating this negative pressure inside the mouth, which draws the milk out. So we see two different patterns of nipple positioning when the baby is tongue-tied. We see a pattern where when the nipple is in the right position in the mouth, and that the nipple needs to be at the junction of the hard and soft palate. So it's pretty far back there. Again, it's breastfeeding, not nipple feeding. Nipple feeding just sounds painful, doesn't it? These babies that are tongue-tied may be able to really get around the length of the nipple, but they tend to kind of clamp down and bite down at the base of the nipple. And that just hurts. It can create a lot of nipple trauma, creasing, blanching of the nipple, some vasospasms coming in. And then you also have babies that use the tongue to block or thrust the nipple forward in the mouth. They're unable to keep the nipple in the appropriate position. So that kind of nipple damage is more prevalent on the nipple itself than around the base of it. Sometimes those babies, they have a really hard time manipulating a bottle and a pacifier. So, the tongue, if it's not able to move freely, the tether or that tongue tie of the tongue kind of forces the tongue to move in a forward rather than that upward motion of what has to happen in order to breastfeed. When babies that are nursing, they need to generate negative pressure within the oral cavity. And they do this by using an up and down kind of motion of the tongue. Baby needs to be able to really form a nice seal around the breast with that upper lip kind of flanging upward and outward. And that tongue needs to kind of come down and cup and elevate the breast towards the palate. When we have a tongue tied, the tongue cannot really elevate, and cupping can be quite weak, and babies tend to kind of slide back or fall off the breast. And as important is the ability for the mid portion, that mid section of the tongue, to be free to kind of elevate and depress, move up and down, right? So that's how the baby can draw the milk out of the breast. So the baby will push their tongue up towards the palate and then drop it down, and that kind of creates that vacuum with that negative pressure. That's kind of the mechanics of what the tongue tie is and what's needed in order to effectively breastfeed. And, there are definitely many signs and symptoms for mommies and babies when we're looking at different types of tongue and lip ties. We may see an infant that is, slow to gain weight or underweight. Sometimes babies are kind of passively feeding when mommies have abundant milk production, and then they can get really frustrated when the milk slows down and they have to work a little harder and it's more difficult for them. We can have babies that seem hungry all the time because, they're having a hard time removing the milk out of the breast. And, again, the trouble with the latching, opening the mouth nice and wide. It can be very difficult because that tongue can't come down and out. And they tend to end up kind of clamped at that nipple. They get very sleepy at the breast just because they're compensating a lot with their lips and jaws to try and almost pull out the milk that way. We get very frustrated babies sometimes. They are really upset that they're having a hard time, and they show it. Sometimes babies have jaw tremors where the muscle fatigue from, the compensation that they're using with their jaw muscles gets very tired. Again, we have limited or, no tongue elevation. The tongue is not coming up. Tongue extension. I mean, some babies, tongue-tied babies, some of them can stick their tongue out past their lips and past their gum ridge. But just because the tongue has that normal function in one direction doesn't necessarily mean that the tongue has normal motion all directions. And that's what we're looking for, is that complete tongue function. A lot of things have to be right for the baby to get that milk out. We can see that high palate, that kind of recessed chin, a lot of those nursing blisters around the lips, kind of looks like cobblestones sometimes because they're holding on so tight to try and maintain, that seal at the breast, and chomping and chewing, and sometimes you're going to hear a sound like a clicking sound of that tongue as it snaps back and the baby loses suction. And sometimes you can see the different shape of the tongue, can also let us know kind of what type of tongue tie is present, which, babies have a hard time getting milk out of the breast. They're latched on poorly. That leads to, suppressed lactation when the breasts are not getting emptied and drained well. So milk production doesn't, isn't established, and it can drop even from what it was. Mommies have really damaged, abraded nipples, and it's just that repetitive crush and roll, and that compression from the baby just squeezing that nipple up against the hard palate. Painful breasts can happen just because the milk is not being adequately emptied, which then can lead to the plugged ducts and the mastitis and the infection, and a lot of different things. So again, what as an IBCLC, as I said, I don't diagnose a tongue tie. However, I'm looking for these things to ascertain what is tongue function, what is is the lip able to elevate. I can visualize some frenulum sometimes. If it's farther back, they can be a little sneaky and hidden under some skin. And I assess how the baby is doing with mommy. Sometimes I have babies that are, obviously tongue-tied, but they have pretty good tongue function. The mother is able to, with some positional modifications and different latching techniques, we're able to get mommy and baby nursing well and comfortably. And, in that case, that we can wait and see a little bit before going to have any kind of procedure to release that. And just, paying close attention to make sure that mommy's not in pain, the baby is gaining well, very, very frequent weight checks, and pumping also to make sure that we are protecting milk production if we do see the baby's weight starting to trend down or mommy's starting to have a little bit more pain in the nipples. So I like to assess that tongue function. We all, to some degree, have frenulum. So I just want to, make sure that before we just look at a dyad, a breastfeeding dyad, my job is to go through all the basics and to say, okay, let's rule out all of the other things, those kind of breastfeeding basics, before we get to the point where we say, okay, well, there is the frenulum and it is causing all of these other things as well. I think that sometimes babies are getting frenotomies and they're not getting all of those basic breastfeeding techniques. They're not getting that kind of ruled out and fixed and corrected. So getting the frenotomy, yes, it's going to help with tongue function, but you still have all of these other challenges and issues that need to be corrected. So I like to start with the basics first and work through it until there's nothing left but to address the tongue and the lip tie. Right.
Wow. Yeah, that's so great for moms to know that this is out there. Especially if there's nursing challenges, it's important to, so if somebody is suspecting it, then how do they get it diagnosed? Who are you referring to?
Well, I like to send babies to providers that have a lot of experience, with working, with breastfeeding babies and how to get it done properly. So, a lot of times people will just go to their local ENT or a dentist that does this. But what I do see happening is that the ENT or the dentist, if they don't have the training and really release all of that tissue, they may release the anterior, the front part of the tongue tie, and leave that midsection posterior tongue still attached. And again, as I said before, it's that mid-back part of the tongue that does so much work to create all that, negative pressure to remove the milk. So if we still have dysfunction back in that part of the tongue, then, it doesn't help that much. So I like to, I have a list of providers that I know well and have seen their work, and that's who I refer to.
Right.
Dr. Scott Siegel is in the city. Dr. Linda Dahl, she's also in the city, and there are some in New York City, yes, and there are some great dentists and ENTs in the area that I would refer to. They basically are the ones that can do the frenotomy, the procedure to release the tongue and also to address the lip tie.
Right. Great. So I think that's so good for moms to know this is available. And, I also, wanted to add that if there is a diagnosed lip and tongue tie, doing the body work, which I know you're a fan of as well, the chiropractic
Absolutely.
and the craniosacral therapy work really well complementary hand in hand with having the procedure done to release the that tissue, but then addressing the structural alignment of the skull, TMJ, and the upper part of the neck.
Absolutely. I find that there is a higher proportion of children that are tongue-tied that have torticollis and some muscle tension and need some body work to nurse effectively. And I also think that getting some body work before getting the frenotomy, the procedure to release the tongue tie, can also really help show even more restriction before it's done. So I like to send mommies before and after. Right. And that's what I see in my office, and I think that's really valuable to do the pre and post op, so to speak. Yeah.
Body work to just help support the tongue literally in learning how to work in that new environment and opening things up and preparing for that release.
Absolutely.
All right. Well, we have to wrap up our call today, but I just wanted to see if you had any last thoughts you wanted to share, and also if you could please give your contact information, your website, so moms know how to reach out to you if they have any other further questions.
Sure. Okay. Well, I can start with that. My website is mahalamom.com. That's MAHALAMOM.com. So you can always find me through there via email or cell if anyone has any questions. My final thoughts are, I'm very honored to be able to work with the families that I do. I find it, a very special career, and I can even call it a job. I love working with mommies and babies so much, and every time I work with a family, I do feel very honored to be, in this time of their lives where they're so vulnerable, and it's just an honor for me, and I'm very grateful to all of the moms and the babies that I've worked with over the years who have really, brought so much into my life, and I'm very, very grateful for them.
Oh, that's so beautiful.
Thank you. I have the best job in the world.
Yeah. I mean, I know your passion, your love for that work is just so apparent, and knowing many clients that you've worked with, I know that they are very grateful for the help that you've given as well.
Oh, that's wonderful.
Thank you for all that you do.
I appreciate it. I appreciate it very much. And I'm really grateful to have you also as part of my care team.
Wonderful. Well, thanks again for coming on the show and for sharing your passion and wisdom regarding successful breastfeeding.
My pleasure. Thank you so much.